Good afternoon. Welcome to our Clinical Culture and Diversity series. For today, we are going to have a speaker talk about HIV infant tracking system and cancer tracking system. This talk, next slide, Stacey. This talk is part of a series that we have yearly, and we have 4 dates that occur throughout the year. We always have it on the third Tuesday of the month. And so the dates for this year was September 19th, November 14th. Today is February 20th, and our next one will be April 16th. And the purpose of this program is to develop cross-cultural competencies, improve patient care, and provide individuals with a comprehensive educational experience to help KUMC become a more diverse and integrated campus. Students, faculty, and staff are invited and encouraged to contribute to today's conversation. We are offering CE credits for today. And so on this slide, you can see our learning objectives. We need you to please make sure that you're signed in. If you want the CE credits, to make sure you have your first and last name. That way you're able to get the credits when requested. We'll have that on our attendance log. And this is our continuing education statement. All of this will be put in the chat, and we have our conflict of interest disclosures as well. Here are the instructions for obtaining CE credit. Again, this will be put into the chat. And if you have any questions after the presentation, we always send a follow-up to the presentation. It'll have the recording, and it will also have the directions on how to get the CE credit at that time. And now I'm going to pass the microphone over to my friend and colleague, Dr. Maria Alonso Luaces. She and I are the ones who were the brainchildren behind the CCDS series, and it's always a collaboration between the Office of International Programs in the School of Medicine ODI office. So Maria.
Good afternoon, everyone. I am very excited to introduce Dr. Gloria Sanama Panga for today's presentation. Dr. Gloria is a guest at KUMC, completing a year of research. She's working with family medicine researcher, Dr. Sarah Kessler. I bet she's very familiar to many people today here on this space, and they're working together on links between HIV and cervical cancer. Dr. Gloria received her MD from the University of Lubumbashi School of Medicine, DRC, in 2015. Dr. Panga is a medical practitioner at the University Teaching Hospital, Lusaka in Zambia. Without further ado, please help me extend the welcome to Dr. Sanama Panga.
Good afternoon. Thank you for this opportunity here to me. I'm very happy to be here. And then today I would like to talk about my research experience at KUMC, which will be on the integration of cancer tracking system into pre-existing health services. Especially this program it will be in the sub-Saharan Africa. Myself, I'm Gloria Panga. I'm originally from DR Congo, here in blue. And I've done all my studies in Lubumbashi, in DRC Congo. From my primary school to the university, I've done it in Lubumbashi, in Congo. And then after finishing my university, my education at University of Lubumbashi, I've worked as a general practitioner for 1 year. And then after that, I moved to Zambia according to the war raging in our country. Our health system is not well defined, and then we have many fragmentation into the health system, which makes our health system very hard to be defined, and then many people tend to use the self-medication, and then on the other side, only a few percent of people can be able to attend to 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 the health care as it's need, or as it has to be according to the WHO, according maybe to the definition of health. We are not fitting in that definition, because for us it seems like we are just staying on the physical aspect of well-being, not into the social or mental and spiritual well-being. No, we are just seeing the medicine as the physical part. And then with that year of research here at Kansas City, it made me think or know that a human being is just a all of wellness. Thank you. I think I can go now into the presentation. Today, I'd like to talk about you on some going research we are doing with the teams from KUMC and Kenya. I'll be talking about the infant tracking system and the cancer tracking system, which is sorry, it's emphasizing on the cervical cancer and breast cancer. These interventions are very sorry, are very relevant for us health providers, and then especially for the community who will be the beneficiary. Can I go on the other one? These cancers have the worst mortality due to the advanced stage at the presentation also, and then there's no screening implemented for it to get diagnosed earlier. According to WHO, this organization urged the countries to reach at least 70% of the screening and treatment coverage, and identify women living with HIV as a priority population. As you can see on this chart, it shows how the cervical cancer is well distributed onto the global Earth, and then in light blue we can see at which age most of women can die with cervical cancer. In Europe and in South America, we can see that many women are dying at age of 55 years. And then in America and in Australia, most of women are dying at age of 57. But in sub-Saharan Africa, most of people, we can notice that the mortality is very premature at age of 18. As I can say, these cancers have shown how in sub-Saharan Africa, it's a socio-economical health burden, and then over 1/3 of all cervical cancer that occur globally happens only in sub-Saharan Africa. And then, but we can say that the cervical cancer is the first cause of mortality among the women, or women in the world. Definitely. Yes, now I can talk about the Earth tracking system. The Earth tracking system is an intervention that improves both to prevent the prevention of mother to child transmission of HIV and early infant diagnosis to attain the WHO global goal to eliminate the new infections. Also, this intervention have shown that many it helps many many people or many women at least to stay in care and not to get lost of from the follow-ups using the funds to at least to return those women and child in care. These charts have shown how this tracking system is very effective and then cost effective. In Kenya, on 100% of people were enrolled into the HIT system were initiated on ACT, that's the antiretroviral treatment. It shows compared to those who were in the standard care, at least 85% who were enrolled in the HIT system have completed the early infant diagnostic service, which is very fast, and then it's very fast, and then which is very fast, and then the results were really on time, and it helps to follow up these children. Can I go on the other one? As the part of my research of my learning here at KUMC, I'm learning the coding process by analyzing interview transcripts done with key stakeholders to better understand how and why some effective cost intervention gets selected or not to the national scale up. This 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 sorry, the facts that can be taken in account for them to be for the intervention to be selected, we need to see which is the cost of the intervention, what is the distance from the places where the people are living and going to the facilities, to know what are the socio-economic status of these women, and then the accessibility to the drugs to receive. And then I would say this program is part of the diversity supplements to Dr. Kessler grant by Christina Pacheco. Yes, with this course, I learned how to code interview transcript and develop a code book. You can go on the other one. Our program this year and for the Kenya studies is focused on the cancer tracking system, which is an adaptation of the HIT system designed to support cervical cancer screening, treatment, and referral for reproductive age women with or without HIV. Also, this intervention used its technology to secure images of cervix taken with coloscope and has the ability to extend the reach of expert providers into remote areas. For example, in the rural areas in our countries, sometimes it's difficult for women to reach the the specialized facilities where they can attend the care, but this system, it helps the the hospitals to save time and cost of referrals, increase also the accuracy of the diagnosis, because if that woman has to take almost a week or 2 weeks to see the specialized doctor, maybe the symptoms will be worse, or we could lose that accuracy of the diagnosis the time she reached that facility. Also, it supports the provider's training, because those people who are in the rural area have to be trained also to help from where they are, not just waiting for people who are far from to come and see those women. This study was launched this month, and then already first participants have been enrolled on the 5th February, on the 5th of this year. In this program, I supported Dr. Kessler's team with the study, startup preparation and development of the study protocols and training tools. Also, I will lend my clinical experience to support the team with the development of the cervical cancer modules. Also, I will work with May Maloba, who is the nurse and investigator on this program in Kenya. Also, I will routinely meet with Kenyan and US study team for the progress and problem solving for this research. Yeah, I would say since I'm here in KUNC, I've become a student. I have another additional global health training, which has been offered by the OIP. It's the CFHI Pillars of Global Health online course, which helps us students to build competencies for global health engagement modules. I think these courses will be very helpful for me according to our our health health system care. I can say each week, but with this program, I think I will learn how to I will learn to work according to the environment where I'm finding, and then according also to the social status of our patient. Another one, also I'm attending the training with the community health workers, and then because I'm I was not used to go and work during the winter because it was too cold for me. I couldn't go on the field. Now the weather does get a little bit better. I'll be going now on the field. And then as a clinical observer in collaboration with family medicine physician, I'm just shadowing in the clinics, and then to see how they are treating the communicable disease such as HIV and tuberculosis. Also, I'm supporting the patient recruitment for family medicine residents HIV focus study at KC Care. Thank you. I can move on. Yeah. As most of countries have recognized breast cancer as the cause of mortality in women as the first cause of mortality. But what we can see in our countries, as in Zambia and in Congo, people are coming late on the late stages of the disease, and then we are not able to give them any care. We have only the opportunistic diagnosis when a woman comes with the disease at that late stage. We don't have much to do. The cost has become very high, and then what we can do is just to do the palliative care, and then at this stage we think that integration of the CAT system into our guidelines, it will really help us to screen these ladies and then to empower them and to save them on time. In summary, I would say for the success of this implementation system, we need a multidisciplinary team approach to achieve the sustainability of this intervention, because this CAT system, as I've learned from the team, they're working with the government, with the oncologists, and then with the leaders on the national level and on the county level. I think with these strategies are better to tackle this problem we are facing, such as the screening of the cancers. Up to now, we don't have any immunization against the HPV, which is the main cause of cervical cancer in women. We need the plan to integrate these in our primary care system. And then also we need to be able to treat these cancers at the earliest stage, which is the precancer, which is the precancer lesions to treat them very early, and to work with the community, which have to be engaged. Most of the time, many women are thinking that having cancer, it's not seen as the medical disease. It's something like a witchcraft on them. And then I think with that, we need to educate those women to educate them to be aware of that, and telling them that it's not just a witchcraft coming from any kind of bad things you've done, but it's a disease. It has the known risk factors, and then it's preventable and curable when it's catch earlier. Yes. Thank you so much for your attention. Knowing that English is not my first language, and then thank you to this program, because it's a cross barrier and help us to learn other culture. Thank you.
Dr. Gloria, thank you. It's very interesting. There's a lot in your presentation. I think a lot of threads that we could, follow and ask some questions. So if anybody has a question, please put it in the chat. I'm actually going to start with one of your last questions. I've kind of made a list, but something that came up at the end, and it just kind of resonated with me. I spent some time on a tiny island in Ponape. It's part of the Federated States of Micronesia. I lived there for 3 years. And there was this belief with sickness that someone had given them like the evil eye, or they believed someone else could make them sick if there was like bad relationships between the people. So you say that there's an element of this in Zambia and the Congo, I guess, maybe? Can you
Yes.
talk a little bit
Also
more about that?
yeah, I would say in Congo, also in Zambia, it's it's quite a fatality to have such disease because you'll be suffering from the stigma. People will be thinking that we have some bad spiritual evils are following you, and then people
Mhm.
will be looking there, will be seeking for the healers for you, and then some people can be ashamed of this status and then so we are going just to retire from the community, which is very hard for these ladies. And then on the other hand, you can see many women to lose also their marriage,
Oh,
yeah,
yeah.
because of that. And then it's very, I don't know what I can say.
So there's a lot of
It's
stigma. There's stigma attached to being sick because people believe that it's caused by something they did or some evil energy attached to them. But then it also causes the individual to withdraw from society and to not seek help. So I guess
And then
the
for
question,
the educated women, which are aware of the disease, but many of them are just saying that these are this disease, like such as breast cancer, is just for white women,
oh,
as like black women can't get such cancer. Yeah.
interesting. So
Mhm.
what do you like when going back? What do you see as the educational process? Like, how will you work to change the community beliefs and the cultural beliefs?
I think for I would say we need to start with the young generation to start telling them, teaching them, organizing some session of education to tell them as it's scientifically proved that the breast cancer is a real disease. It's not it's not originated from spiritual things. And then also to try to involve many of our leaders, such as the traditional leaders, also they have that big responsibility to talk to the member of the villages that this is the real disease. We need to work on that. And then I would say maybe for women who are above 60 years old, we can say it's almost late for them to start being teaching about that. We need to start with some people at least at at 12 years and above.
Hmm. Hmm. So, Dr. Gloria, is it possible to have educational programs in the schools to
Yeah,
utilize like the schools and reach out that way?
exactly. It's possible. It can be even put into the curriculum of
Hmm.
education. It's
Hmm.
possible to do that with the government.
Hmm.
Mhm.
Hmm. Do you have experience, you and your husband, Dr. Kinda, do you have experience in engaging the Ministry of Health and the government in these type of programs?
This one, as I mentioned earlier, it was like being a doctor. You are just focusing on seeing people, and then it's just people who are on the human resources administration is the one who are just get involved into the community areas. But I
Mhm.
think this approach was like a tunnel vision. It's really wrong. But for now, I think we need to see it on the other way.
Yeah, well, as you and I were talking before the presentation started, I mean, you're busy as doctors, you're seeing patients, right? So you're very focused on the immediate, like what's going on with the patient and trying to just help in the moment. And as we were discussing, there are all these other factors that the pillars of global health talk about, right? So the environment, and One Health, so animal health, and then health systems. By the way, Dr. Gloria, we just got a note yesterday that CFHI added another pillar. So now there's 8 pillars, and the other one is health systems. So what do you think, because I know you're very happy about the pillars and it's made you think about, more, like kind of globally and all the different systems that it's kind of that ecosystem of health, right? The ecosystem. So what will you like, how is this applicable to your work in the Congo and Zambia? And how will you utilize this in the future?
Okay. In the future, I need to utilize this because as use as learning the research, I need also to be part of the research because with the research, it will help me to understand what is happening in the communities, and then I'll bring it straight to what we are seeing with physically, and then it will help us maybe to see which patient will be to look for the equity into the treatment, maybe who will be get access to this care, which maybe with this account, at this cost, we can see these people and the other people, which cost are we going, how much are they going to pay? Also, another thing is we don't use as much as insurance health.
Mm, mm-hmm,
People are just paying straight from the pocket, which is very hard because in Congo, the lower class, we don't have like the middle class. We have just only which are very higher classes and the lower classes. We have that gap. And then if it could be possible with this program to create at least the middle class where people can
mm,
afford
mm-hmm.
healthcare. Yeah.
Yeah. Marie, Dr. Alonso, were you going to say something? No. Okay. I didn't
I
know
was
if
just
you,
listening.
okay. Okay. Um, Well, I really appreciate all the areas that you are working in here that correlate back to what you do as a family medicine doctor in Zambia. I know you also mentioned communicable diseases and how, like tuberculosis is treated here. And I'm curious, like in your setting back home, what communicable diseases do you see, and how what you're seeing here is different than there? What's similar and what's different?
What is similar? It's just the chronic disease such as diabetes, hypertension, they are quite similar. Also, the treatment are similar.
Mhm.
But the main difference I'm seeing it's just on the preventive care.
Okay.
Here, the program is very focused on the preventive care, but as we kind of treating the second phase of the disease. We are not focusing on the prevention,
Yeah.
which is hard for
Yeah.
us to have the good outcome.
Yeah, and you mentioned that relative to cancer, that you need to catch it early and be preventative, because when it gets to late stages, you don't have the ability to treat that, right? So that I can see where that's really important. And then that also gets back to education, right? Education in the schools. Your husband, Dr. Kinda, has a question. Dr. Kinda, go ahead. Unmute yourself. You have a question. I see your hand up.
Okay, not really a question, but a comment.
Please.
Okay, I'm actually, Gloria, I'm very happy with your presentation, good presentation. Actually, what I can just say, and give you an example of my mother. She died from breast cancer.
Oh, I'm sorry.
She was learned, and she's not like someone who's didn't know about that, because she's learned. She was a teacher in the past and everything.
So she's
But
educated. She had knowledge.
yeah,
Yeah.
yeah. But myself, I came to know about when she was already in the last stage.
Mm.
Okay, yeah, I was in Zambia. Sometimes we're just talking to the phone, but she will tell you about some other things. They will treat about malaria or these other things. But I came to know about breast cancer when it was at the last stage. Actually, what Gloria says is that what happened with a lot of our patients. They come on the stage where you are unable to save them again. Yeah, and actually, from Gloria, then I learned again that there is vaccines for survival, because I've never heard about back home. And actually, those are the things. Those kind of disease, they are more, it's secretive in a patient don't want to disclose. And I think that's a big issue, which actually need a special program to actually try to solve that problem. Yeah, and actually, I'm very happy with the presentation. As what happened, most of the doctors that treat the disease, they are mostly in the clinic. But with actually what Gloria is doing, just to do things a bit differently, means to go on the roots of the problem, which actually can be. Actually, that's a better approach for all these problems. Yeah, that's my comments.
Thank you. Thank you for sharing that. Again, sorry for your mother passing. I know that's difficult, especially as a doctor. I'd like to focus on kind of a strengths-based approach. And Gloria and Dr. Gloria, you're being here, you're seeing. What do you appreciate about Zambia and the Congo now that you're here? Like, what do you think is the strength of your system and your patient care?
What I think here I didn't find here in US is that accessibility to the doctors. Like when I reach here, for me to be able to see even a primary care doctor, it takes me 2 months, which is quite impossible with us. Even if the cost of care can be very high, but to see a doctor in Zambia or in Congo, it's just straightforward. That's why I can say that in Congo and in Zambia, we have VIP people because we are seeing the doctor whenever we want.
I love that. Yes, everybody's a VIP. Everybody gets to see the doctor. Yeah, it is an issue here. And I don't know, like, is it a numbers issue? I'm not sure why we have to wait so long, but I do know it's because appointments are out that far, right? There are no appointments available. So it puts us out, several months. And it's a very, that's a very interesting difference, the access to doctors. Mm-hmm.
And then also you need to learn how to use your insurances. They they are fragmented. There's this insurance for this part or many small parts of insurances. It's not in a whole and explain. You need to get insurance for your eyes, for your teeth, for this. That is too much for us.
It's very confusing. It's a big part of health literacy is understanding your insurance. And for me, it's like taxes and insurance. I just I don't have time for it. It's so overwhelming for me. Like I have a
And
hard time.
then
And
I don't even understand what they're saying.
yeah, it's very, and and then it's so time consuming. I had my son got injured when he was playing basketball in Colorado. And so instead of sending him to the emergency room, which I knew would be very expensive, I sent him to a chiropractor just to evaluate if it was broken or not. Well, that chiropractor wasn't in the health insurance system or something. That was last August. So we paid like $600 at the time for him to be seen. And we've yet to get the reimbursement from our insurance. And it's like this three-way conversation between the chiropractor, the insurance, and me. And at some point it's like you just say, okay, I don't have enough time to solve this issue, right?
Yeah,
It's
exactly.
so complicated.
Yeah. Also, another strength we have in many parts of Africa,
Mhm.
you can be a general doctor, but you are able to perform many other specialties on your own.
Is that, and I'm from my experience, so it's kind of a question, kind of a statement. What I've heard in working with our rural physicians in Kansas, I've heard there's a lot of similarities between our rural doctors and a lot of international practitioners because of that, because they're general doctors who end up developing the specialties because they are the people who are available to the patients. Is that kind of how it is in Zambia? Or is it like a rural
Yes,
doctor?
if they're especially in the rural areas. Yeah, it's
Mm-hmm.
how it is.
And is it because of a lack of specialists that then the general doctors just have to dive into those
Especially
areas?
people, there's some preference for specialization.
Mm-hmm.
Many people are going into that field where they'll be having man some fast, we can say fast money,
Oh, yeah.
things like
Mm-hmm.
surgery,
Yeah,
gynecology, yeah,
right. Yeah.
where you have to just have an intervention and then you got your
Yeah.
money.
Mm-hmm. Mm-hmm. So for you, Dr. Gloria, since you are a general doctor, but you have experience in many areas, tell me what area you love the most that's more of a specialty area. Like what is the most pulls at your heart and interests you the most?
My preference and then my desire is to work with the children. I would
Okay.
like to be a primary care, but more focused in children because I think as one of our professors was telling us is the children are the most honest human being we can have. They can't lie about what they're feeling.
Yeah. That's true. Well, your face just lit up when you said children. So I think that you do have a special love and a draw to that area.
And
Dr.
then I think why also I love the pediatrics field. During my childhood, my mother told me that I used to be sick from from 0 up to 5 years.
Uh-huh.
On under 5, I was like sick every single night. We have to go to the hospital. And then after that, I don't know if I've ever been sick again. Yeah.
Do you remember being sick as a child?
As a child, no.
Okay. Okay.
But since my 5th year up to now, I've never been sick in the hospital. Yeah.
Now you're healthy. You're not yet. That's great. Well, it has been such a pleasure chatting with you and getting to know you better, getting just a glimpse of Zambia and the Congo and what you're learning and supporting here. And I know you're a great addition to the team. And knowing the team that you're on, they're learning a lot from you. It looks like Patrick has something. I'm sorry, Patrick. Dr. Kinde, you have one more thing to say. Go ahead before we wrap up, please.
No, I think that's the first
Oh, okay.
raised hand.
It's
Yes.
okay. It's still up from before. Okay, great. All right.
Okay.
I don't know how to lower it. Anyway, okay, but anyway, thank you so much, Dr. Mpunga. You've been wonderful. I appreciate everybody who attended today. And as you know, this will be a recording. It'll go out to everybody and you can share it with whoever you'd like as well.
Also, I would like to thank you, Christina. Thank you so much for your time.
Thank you. Thank you for being here. Thank you, everyone.
Great job,
Thank
Dr. Gloria.
you. Bye.
Thanks, Christina. Thanks for being here.
Thanks.
Thank you, Dr. Wildliff. Good job, Gloria. Good job.
Okay, bye.
Bye.
Thank